And I'm going to talk a little bit today just about navigating the postdoc landscape, but particularly thinking about that relationship with your manager, why that might be a barrier and some of the things you might be able to do to kind of overcome that, that barrier. So I'm going the right direction. I'm a consultant clinical academic physiotherapist, and I work for Portsmouth Hospitals University Trust. And Portsmouth Hospitals became a university trust in 2021, right in the middle of COVID. And so it's been a kind of a bit of a slow start to build on that partnership. But what it has done is had a real renewed focus on clinical academic careers and how we might build partnerships and collaborations with Portsmouth Hospital, with the University of Portsmouth. But my role particularly is, my clinical academic role is as the therapy team lead at the Portsmouth Enablement Centre, which is my clinical role. The Portsmouth Enablement Centre provides prosthetic rehabilitation to people undergoing lower limb amputation. But I'm also seconded to the University of Southampton, where I teach on the Masters in Amputation and Prosthetic Rehab. I'm the clinical lead for the People Powered Prosthetics Research Group, and I'm also doing my PhD. And you might say, well, if you're doing your PhD, how can you talk about this postdoc landscape? But actually, I've worked for a long time in research and development with Solent NHS Trust, where I was supporting their clinical academics. And I also now am the co-lead of the PHU Clinical Academic Hub, with my rather fantastic colleague Rosalind, who is in Portsmouth at the moment. And the Clinical Academic Hub supports nurses, midwives and AHPs to get involved in research. And so we work in a really coaching, kind of supportive way as people come forward to talk to us about how they might like to get involved in research. We talk to them about whether that might be through research delivery, whether they might like to work with academic colleagues to collaborate on grant applications and the development of new research, or whether it is clinical academic career pathways that they are particularly interested in. And we have a website which you can check out, which has got loads of resources on it if people are interested. But one of the, what I wanted to really highlight today is why this postdoc landscape is so challenging. And we know it is challenging because it's documented already in the literature. That we are here today is another reason why it's challenging. The need for sessions like this to really focus on supporting that kind of drop-off gap period. And that there are bridging awards available from organisations like Art Wessex to help get through this period, the Advanced Clinical Academic Fellowships. And there is definitely, in terms of NHS roles, a real dearth of NHS-based clinical academic posts. And what they might look like. And there's definitely more emerging roles now where we might look at shared positions, but how they come together then is very dependent on the individual. And there's a lot of kind of bespoke posts emerging and not a sort of a standard model for this. So Portsmouth actually has quite a long history of supporting clinical academic development, and particularly through the amazing work of Greta Westwood. When myself and Rosalind started in this post, we wanted to have a little look at what had been happened before and how we could learn from that and where we might need to focus our efforts going forward. So we reviewed Greta's model. Greta's model supported people from trusts across the Wessex region. We just focused on PHU. They looked at joint funding between the hospital and university to support clinicians to undertake PhDs. And so from 2011 to 2017, 25 clinicians from PHU started their PhDs. And so we wanted to have a look at what had happened to those at the end of the programme to get an idea of how big this problem was. And so what we found is that PHU retained 6 of those 25 people. 3 of them didn't complete the PhD, they exited with a master's and were back in clinical roles. And the 3 that did complete, one of them was in a completely clinical role, 2 of them described themselves as research active, with one as a research nurse, and the other being Rosalind, who is in a clinical academic leadership post and is sat in Portsmouth. So actually, for 25 clinicians, from a trust perspective, that's a 4% success rate to get people into a position to be research leaders. So this is a real issue for people going through a PhD, this big drop-off. So what did we do? So we wanted to get a bit of an idea of why this might be an issue, try and identify some of the barriers and facilitators, and advise the trust on where they should focus their efforts. So we undertook a year-long project where we did a massive stakeholder engagement piece. We mapped our internal and external stakeholders We identified those with the most interest and influence in terms of clinical academic career development, and we undertook interviews and focus groups with them. And we found that managers are a real key stakeholder in clinical academic career development. And we heard this from our clinical academics, but also we were hearing lots of kind of barriers and issues from the managers that we spoke to. And so what I've done here is just summarize some of those facilitators and barriers from a manager's perspective. And so this is really useful for us as clinical academics to think, actually, how can we address some of these barriers? How can we really ride these facilitators to get the best outcomes for ourselves? So if we go through them, in terms of facilitators, managers found that the income generation was a real facilitator. So the fact that the fellowships came with funding that bought the person out, that was a real positive. And they could also see the benefits of future grant applications that could come in, cover the salary costs of your clinical academics, but also perhaps bring in additional funding for training of others to build capacity. They were absolutely on board in terms of recruitment and retention. That they felt that it was often when they were thinking about promoting the department, having someone who was research active was a part of their promotion to try and attract new staff into the department. They were really keen on education and development, not just of that individual, but how that individual could have a transformative effect on the team around them, how the skills that that individual was developing could then filter down to other people. But they were really concerned about visibility. And so they wanted the clinical academics to not just get their fellowship and disappear for 3 days a week to do their research. They wanted to know what they were doing. They wanted to see them. They wanted to hear about that work. And often there were lots of stories of people just disappearing and the managers feeling really disconnected from the research and ultimately seeing no value to them in that post. Value is a major barrier for the managers. They really struggle to see the value of these clinical academic posts, of what it will bring to them. They can often see the value of what our research might do for the profession, for the specialty, but what they're particularly interested in, what they appeared to be interested in, was the value to their department, to the trust, to their trust. There were also loads of practical issues for them. It was really hard for them to backfill these posts, especially for some of the short-term internships that were coming that might last 6 months. They often didn't backfill. And so they were taking the funding, but clinically they were taking a hit in terms of their service delivery. And on fellowships that lasted a couple of years, and then there was a gap with a plan to go again, managers struggled to know what to do in that gap. And so actually the practical issues of managing those posts was challenging. There's a real lack of clarity about the structure of the roles, how they should be banded. What happens at the end of a PhD? Is there an expectation of a band change if research is not written into the job description? How do these clinical academic roles align with ACPs, align with consultant posts? Are they the same? Are they different? And finally, managers felt absolutely lost with how to support their clinical academics. They didn't know what the pathways were, they didn't know how to signpost them, and they found it really, really difficult to know how to kind of support people to go on. So, knowing what we kind of know from this, how can we, as clinical academics, take that information and really use it to our benefit to help navigate this kind of difficult drop-off phase? So what can you do? And I wrote lots of stuff down, so I had to write it on a piece of paper so I wouldn't forget all the advice that I was kind of generating from these findings. So one of the things I think to really think about, and whether you can think about this from the beginning of perhaps your PhD, whether it's something you're thinking about in the middle or when you're looking at postdoc projects, can you align your project with the trust or the department's priorities? And it may be it's just a case of sitting down and really articulating how the work you're doing does align with your department's priorities, with your trust priorities, so that you can talk to your manager about that. And that can be challenging with the academics, because academics will be thinking about some of their own research interests, but they're also trying to shape your project into something that can become a PhD. And you can get a tension between what's really clinically important and what a good PhD might look like. And it's about keeping that conversation going. How can we manage that tension? How can we make sure that we don't lose sight of the clinical impact and of what's important to your team and your trust? You need to be really flexible around your planning. So it's really hard for your managers to backfill you. So can you go to them with solutions? You've got something coming up, you've applied for something. Can you take a solution of how it might work? Where might they get the backfill from? Can you pitch it in terms of succession planning? Can you find out who the finance person is in the R&D department and be the go-between between your manager to make sure that the money that's coming in for your award ends up in your manager's budget and they're not feeling like they're missing out on that? Help your manager to understand clinical academic roles. And so that might be by arranging a meeting between your manager and the trust clinical academic lead or research lead. And so that as a kind of duo, you can help signpost your manager, tell them what that work might bring to their team, help them see the value, and make sure that that development is not just about you, but about the transformation of the team around you. Also, really good practice to link your manager with your academic supervisors, and things like tripartite meetings where you're all meeting together a couple of times a year to really keep your manager in the loop about what the research is about. And it's also really useful for you to get a second person's input in terms of the clinical impact that your work might be having. In terms of future research grants, they are obviously bringing in income. How can you use that grant income to build capacity? So it might cover your own salary, but could you develop other people in the team? Could you start to think about a pipeline of researchers? So you're kind of replacing yourself as you start to move forward. Help your manager to showcase your role within the team. So thinking about promoting your work and your role. So we're encouraged to do that anyway as clinical academics, poster sessions and conference presentations, but really pitch that as your department. Think about how you can build the reputation of your department for research and help hit that value point around retention and recruitment for your manager. Share your newly found knowledge with your team, in-service trainings, journal clubs. If your manager's got a particular initiative, can you do a literature search and find them some evidence? Can you help interpret that evidence for them? And they often, managers see value much more easily in audit and service evaluation. Your skills as a clinical academic are ideal to support service evaluation and audit. Can you be their go-to person? So essentially what we're talking about is how can you make yourself the most useful person in the department for your manager when it comes to research and improvement? And finally, be visible. Don't just disappear off home. It's so tempting because you know you're going to be more productive at home. But can you do at least one of your research days in the department? Talk to your colleagues about your work. Be the most boring research person that they're constantly going on about your own work, and influence those around you. So there are tools out there that can kind of help to navigate this postdoc landscape, and the DNARC toolkit is a good example. It's built for nurses, midwives and AHPs to help as a checklist to kind of go through thinking about the things that you might need to have in place as you come towards the postdoc period. And it talks about disseminating, implementing, about networking, continuing to be research active, but also clinical career development. One of the other things to consider is a lot of these kind of posts now might involve a joint post between the university and the trust. How can you build ongoing relationships with the university as well as with your trust? So thinking about, can you support teaching? Not only does that hit the big value points for HEIs, it's definitely teaching. You can also then share your research findings with the next generation of clinicians that are coming through and really start to hit those pillars of advanced clinical practice. So I then wanted to kind of put all of that into context with what I've been doing. So you can kind of see how perhaps on an individual basis, you might take that kind of knowledge, and I'm going to talk a bit about what we've done at the Portsmouth Enablement Centre. And so we absolutely were influenced I was influenced at the Portsmouth Enablement Centre by my experience supporting other clinical academics, hearing people moan about other clinical academics, hearing clinical academics moan about their departments and their managers. And so actually what I realised is nowhere is it written what a clinical academic does on a day-to-day basis, what their role actually is. And there's a brilliant paper by Cowley et al. That really highlights the need for clinical academic roles to move beyond being transactional. So I go to my PhD lectures, I run my project, I gain that knowledge, to being transformational. So I use that knowledge to generate change in everything that sits around me. So at the Portsmouth Enablement Centre, we are, just to give you a bit of context, we're one of 44 prosthetic centres across the UK, so we're a specialist centre. We provide rehab following limb loss and lifelong care. We're a fully MDT approach. We often work with private providers. So in Portsmouth, we work with a company called Steepers, and we're also an enhanced veterans care centre. And so in terms of research, when I was kind of a couple of years back, I was really thinking about how do I bring all this together? How do I do the transformational thing? I kind of came up with these sort of 4 areas that I felt really needed focus. And you'll be able to see how these kind of correlate back to the information that we found from our managers. So I'm going to go through each of these in turn. So about building capacity and capability in the team around me to do research, about building partnerships and collaborations, because there is no doubt research is a team sport, how we can make research our core business, and how can we do all of this with patients slap bang in the middle of it. So I start with capacity and capability. I wanted really to ensure as many of the people that I worked with were getting involved in research. And one PhD project is quite difficult to get 30 people involved with. And so I was doing my PhD research and lots of people were helping me recruit to that or were taking part in it. And that helped us to develop some of their research skills so they could understand different methods, learn about informed consent, but also see what healthcare research looks like. But one project wasn't enough. So we really got a lot of people involved through doing more research delivery. And so we worked with the R&D team to identify studies that we could recruit with our prosthetic patients. And over time, we were able to build up a portfolio of studies. And I was doing a lot of this work on my own. I was acting as the PI, but I was also recruiting patients. But what I was able to do then was, as different studies came up that people were interested in, prosthetists started getting involved. And then the OT started getting involved, and the nurse. And we built up quite a good amount of activity that the trust funded us a permanent 0.2 whole-time equivalent research prosthetist to kind of take a lot of that work off me. And that's a rotational role now. So our prosthetists come into it every year. And so they get lots of in-depth experience in getting involved in research. The whole team were GCP trained. So they've kind of got almost that mandatory training kind of level of research. And we also then could do more homegrown research because we had this real sort of changing knowledge about what research was. And that led us to be part of more than 8 applications and currently £1.1 million worth of research income, which hasn't, unfortunately, all come to the trust. It's spread over the organisations that we work with. But I think it demonstrates how successful you can be when you're really embedded clinically. So in terms of partnerships and collaborations, we couldn't have done any of this without the partnerships and collaborations. We were too junior. We didn't know what we were doing. And we absolutely needed them to guide us. And a lot of those partnerships came through research delivery. For example, there's a big study from the University of Hull, came in, we delivered it, we did a really good job, we were really engaged with them, and they asked us to be collaborators on their next grant. The People Power Prosthetics Research Group has also been absolutely integral. So that's formed of my PhD supervisors, Pete here, and helps to bring together academics and clinicians and patients who are interested in prosthetic research. But we also widen the collaboration. So we collaborate with the University of Portsmouth, the University of Hull, the University of Nottingham, the University of Salford, as well as small and medium enterprises. And as we kind of did this work, we started to realise that Portsmouth was quite unique and there weren't many other centres that are very research active around the country. And that can then cause problems when we're looking at multi-centre studies. So I also set up the Amputation Rehab Research Network, which brings together clinicians in prosthetic rehab and academics to help try and address research capacity and capability across the country. So in terms of our core business, I really tried to weave research into our day-to-day processes. So we put it as an agenda item on every single meeting. Everyone was bored stiff by the time that I was, I was always the person. Now I've got research prosthetists and the 2 of us now are talking about it. We also did clinical issues workshop with our academic colleagues. So the University of Southampton People Power Prosthetics Group, they came over. We ran some sessions where we were saying to clinicians, like, what are your biggest problems? How can we use research to address those? And we use them as ideas for our master's students on the master's module. We also mapped all our routinely collected healthcare data. So how could we use stuff that we do every day for research? And have currently got an RFPB and awaiting in the second round of that to explore how we can use that routinely collected healthcare data for patient benefit. And then finally, how do we get patients involved in all of this? And so actually within prosthetics, patient engagement was really embedded in what we do. We have a user group, and so we invited patients from our user group to become part of People Power Prosthetics. And that allowed us to have patients as co-applicants and to make sure our projects were really driven by some of their problems. But we also got some funding very early on to do some larger PPI work to try and understand what patients felt were problems with their prosthetic limbs. And we produced this infographic, which we shared everywhere, to help try and not only influence our own research, but influence what was going on elsewhere to make sure it was really driven by the voices of our patients. And so through these kind of really 4 areas, we've been able to try and really transform it just from me sat there doing a PhD and building my research knowledge to that research-led care environment where we're really using research to guide lots of our decisions and to answer lots of our problems. So in summary, clinical academic roles need to be really transformational, and this is where you're going to hit the value with your managers. It's like, and it's also not your managers that are going to ask you to do this, because they often can't see what this is. This is absolutely at the moment up for us to drive. And we are trailblazers. There is no doubt. A lot of this stuff hasn't been done before. It's not written anywhere, and it's working out what works for you in your department. You need to absolutely demonstrate the value you can bring wider than just building your own skills, and take your manager and the whole team with you on your journey, whether that's your PhD journey or your postdoc journey. But also think about building longer term relationships with your academic teams so that when you finish your PhD, you're not then adrift. You've got a team that you're embedded within that you can then go on to help collaborate on future grant applications. So ultimately, be flexible and creative. And when you get to this kind of picture at the bottom where there's absolutely a risk of this drop off, sometimes it is going to be a leap of faith to get across it, and be creative and think about how it might work for you.